Hello everyone, my name is Mikael Lindstam. I'm the founder and CEO of Aptahem. Why are we running this event today? Well, 50 million annually around the globe are hit by sepsis. 11 million of them die. It's an awful figure. And sepsis is not a well-known condition. And if you compare to cancer, which have much fewer cases or deaths per year than sepsis, then we need to talk about it. And today we are in the World Sepsis Day. And that means we would like to raise some awareness and inform you about sepsis, so everyone can know a little bit more on how to handle it and get care in time if you would be struck by sepsis. I welcome you all to this seminar organized by Aptahem to hear several researchers and healthcare professionals talk about their and Aptahem efforts to bring more clarity and a solution to sepsis. Well, short about Aptahem. Aptahem develops aptamer-based drug candidates for treatment of acute and life-threatening conditions, where both coagulation and inflammation occurs in the process. The lead candidate, Apta-1, is developed towards sepsis, especially to threatening organ dysfunction or tissue damages. We have our headquarters in Malmö, in Sweden. We were founded in 2014, and we are traded because we are public on the Spotlight stock market. So, why is Aptahem and its drug candidates so fantastic? Well, we think we are revolutionizing the inflammatory treatments. And here's some examples to why we see this. Multifunctional aptamer portfolio. We have 3 aptamers in protection. One of them we have as a lead, as you know. I mentioned that before. Lead candidate is on the way to the clinic now, and we are doing that for an acute treatment. The new mechanism rather, that Apta-1 and its brothers and sisters have is that Apta-1 modulates inborn immune response. That's very important to remember. And this is by a multi-mechanistic behavior to affect coagulation and inflammation in a way to recover the organism, immune system and health. A fantastic treatment. And why are we doing this? Not only because we have a fantastic candidate, because there is a huge unmet need. The unmet need is that people, 50 million are struck by this every year and 11 million dies. And of course, that boils down to that every 4 seconds someone passes away from sepsis. It's incredible and unlucky, really. So we are doing our best to help out in this situation. We have a strong patent and data portfolio. Patent is important for us as a company to get it to the market. No one would never invest in such heavy investments to take it to market if we couldn't protect the product. That's the economical side of things. But we have a fantastic data portfolio that supports everything we've done so forth in preclinic. And going forward now, I just mentioned we have done a lot of preclinic. We have now a little pinky toe into the first clinic that we are now entering into next year. So look around at Aptahem and you will see what will happen there. History in short, I will not go through all this, you can read for yourself, but you see the span and what happened, and I can just say in general terms what happened at Aptahem, that the more knowledge we got, the more collaboration and interest we have achieved. We have fantastic collaborators coming in through the years, especially on the manufacturing side, where it's not an easy task with such a new group of chemists that we're working with, aptamers, to scale up and get good cost efficiency in this. We created a lot of fantastic collaborations with different research groups around the world, which have enhanced our knowledge really in big terms that makes us stand here today and saying that we can soon go to clinic. It's a fantastic collaboration that we had so far. And of course we have our own in-house efforts of course. So now this year, 2021, we have a fully granted patent family 1, which is on the structures, and we are now gaining granted status on several of the countries we applied protection for with patent family 2. And that is a use patent. That means it's a patent that protects the therapeutic use of Apta-1, our lead candidate. And if we look at what will happen the next of the year and what happened now and where we are, so we conclude the GLP tox, which is mandatory to fulfill the regulatory needs that the authorities actually demand of you. So as I said before, we are in a pinky toe situation into the clinic, and the clinic will be healthy individuals, which is a standard procedure when you do these things in phase 1 clinic. And then we will also add a proof of concept study for healthy individuals. during these studies to add value and better knowledge before we go into phase 2 for the company. With that, I leave the floor to our presenters and hope that we can contribute to bringing some awareness and knowledge in the area of sepsis from various perspectives. Thanks.
I'm pleased to welcome Mats Eriksson, Associate Professor of Anesthesiology and Intensive Care at Uppsala University. Welcome, Mats.
Thank you, Mikael. It's a pleasure to be here and to speak on sepsis, which has been one of my most intensive research areas during many years. So I hope that I'm able to contribute with some information on this issue. And this is the title, Sepsis, Clinical Manifestations, Treatment, and Ongoing Research. The global burden of sepsis is very heavy. I haven't seen any recent figures about sepsis in the world, but in 2017, almost 49 million cases of sepsis and approximately 11 million sepsis-related deaths were reported, and that's about 20% of all the global deaths. So this is a major cause of death. Furthermore, almost half of all global sepsis cases occurred among children, causing approximately 20 million cases in children and causing about 3 million deaths globally in children under 5 years of age. One within bracket refers to the reference, which will appear at the end of this presentation. What is sepsis? In daily life, we call it blood poisoning and say that it's a bacterial growth in the blood, which is true. But it's a bit more complicated than that. It's usually defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. And what does that mean? Well, organs such as the heart, liver, brain, lungs do not function normally, because there is a reaction against the bacterial or infectious agent. Sepsis is associated with an in-hospital mortality which is greater than 10%. So it's a major killer even in the hospital. And going from worse to even worse, septic shock. It's defined as a subset of sepsis. This is a special case of sepsis in which there are more expressed circulatory, cellular, and metabolic abnormalities which are associated with a greater risk of mortality than with sepsis alone. Therefore, septic shock is associated with a hospital mortality which is about or even a bit greater than 40%. What is sepsis and septic shock like? If sepsis isn't recognized early and managed promptly, it can lead to septic shock, multiple organ failure, and ultimately death. And multiple organ failure is what I previously talked about, the disturbances in heart, lungs, brain, liver, kidney, etc. Sepsis is the most frequent serious complication of infection, and it's particularly present in low and middle income countries, where it represents a major cause of maternal and neonatal morbidity and mortality, making it even more tragic. What is sepsis and septic shock like? Sepsis may be a consequence of clinical deterioration of common and preventable infections. This means that even a rather simple infection could have bacteria, usually bacteria, entering the bloodstream and causing reactions upon this infection. This may be a result of infections acquired in healthcare settings, one of the most frequent adverse events during healthcare. So it's a bit difficult to be dangerous to be in hospital, and of course during surgical procedures there's always an increased risk of infections depending on the organs and circumstances. Clinical signs of sepsis. What does a patient look like with sepsis? They are sick, first of all. There's a rapid breathing and increased heart rate. The pulse is weak and the blood pressure is low. There's a shortness of breath, and usually there's a confusion or disorientation, which is a sign of cerebral affection due to the infection. Fever, shivering, or feeling very cold is usual. Some may not have fever, but a lower temperature than normal. Patients are often sweaty with a warm skin, and this is the warm shock, which is in contrast to, for instance, bleeding shock, where the patients have a low blood pressure but are peripherally cold. The typical septic patient has a low blood pressure and warm skin. The urinary output is usually low due to dehydration, which is very frequent in sepsis. A few biochemical events during sepsis. Release of inflammatory substances as cytokines, especially TNF-alpha and various interleukins, appear to be the main causes of organ-injury sepsis, which may lead to cell damage and death. And for those of you, which is probably the majority, who haven't heard about the TNF or interleukins previously, what are they? TNF-alpha has a central role in the inflammatory response, and it's expressed by certain cells in the blood. The main effect, because it has a positive effect originally, is to activate the body's inflammatory response. Among these mechanisms, TNF increases expression of additional molecules on the endothelial cells. The endothelial cells, they are inside the vessels. And this TNF induces fever and may contribute to the formation of blood clots. TNF is the main cause of septic shock, which is a life-threatening condition, as previously said. And TNF causes frequently an exaggerated inflammatory response, which may lead to cardiovascular failure. This is more of a rehearsal about the coagulation abnormalities, which are partly due to the TNF, but not only. Activation of coagulation system is seen in sepsis and septic shock, and this may vary from a small decrease in platelet count to disseminated intravascular coagulation with manifest thromboembolic disease, which contribute to multiple organ dysfunction. Identification of clinical signs and symptoms of sepsis in combination with analysis of certain biomarkers are crucial for early diagnosis and appropriate clinical management. Early recognition of the pathogen leading to sepsis are important for adequate antimicrobial treatment. So, this is just another way to say that the bacteria should be treated with the right antibiotics as soon as possible. Furthermore, abscesses may be present and may be a cause of sepsis, not infrequent after surgical procedures or where there's been an infection. If there is an abscess, which is a formation of bacteria and pus in the tissues, it should be drained. Sufficient fluid resuscitation is important in the initial phase of sepsis management, and the patients often lack several liters of crystalloid fluid, so you should administer fluid at a rather high speed to make sure that you're filling up the vascular system and improve renal function to increase urinary output. Vasopressors, what is that? Drugs causing elevated blood pressure, helping to increase the blood pressure, are frequently required to improve and maintain tissue perfusion, which is a very central aspect because the blood must penetrate into tissues in order to deliver oxygen and metabolites. Artificial ventilation, the ventilator treatment, and renal replacement therapy or dialysis may frequently be necessary, and that's when the lungs or the kidneys do not work properly. Thrombotic events may lead to ischemic events and ultimately limb amputations. This is not so very frequent, but still it's a well-known complication and it occurs sometimes. Thanks, most patients do not have to be amputated, but it occurs, and it's especially known with some types of bacteria, and the worst one is meningococcal bacteria, which are very eager to form thrombosis, which may cause ischemic complications. Is there any ongoing research on sepsis? Yes, there's a very heavy research going on, which of course reflects an unmet need for causal treatment of sepsis. If you're making a search on the clinicaltrials.gov using the words sepsis and therapy, you can see that there are more than 1,600 clinical studies ongoing. So there's a huge need for new, more causal treatment of sepsis. These are the references, and if you're interested in looking at them, they are free. So you can go and have a look and educate yourself. Thanks.
Well, thank you so much for that presentation, Mats. It's very interesting. I mean, it's obviously a very serious condition, sepsis. I wanted to discuss antimicrobial resistance. Is it a big issue when treating sepsis?
Yes, differs from country to country. Antimicrobial resistance is a minor problem. It's not non-existent in Sweden or Scandinavian countries, but it's a minor problem compared to many other countries where antibiotics are prescribed much more liberally, or even in, I would say, worst case, people could go to pharmacy and buy antimicrobial drugs on their own. And this causes very large problems with antimicrobial resistance. And due to traveling spread all over the world, resistant bacteria are spreading more and more globally. So it's an increasing problem, yes.
Mm-hmm. Speaking of spreading microbes, we've looked at some of the similarities between sepsis and COVID throughout this seminar, but could you maybe go through some of the similarities between these two diseases?
Yeah, there are many similarities and of course differences. COVID-19 is caused by virus. Sepsis is usually caused by bacteria, in some cases by fungus, and to a minor extent by virus. In both cases, there is an overreaction of the inflammatory system, which is more expressed in COVID-19, and it's probably so that the host defense, the inflammatory reaction, is having an overactive response in COVID-19. This could also be the case in septic shock, but it's more expressed in COVID-19. Another difference, maybe the most important one, is that COVID-19 is a pandemic. Sepsis is a widespread disease, but it doesn't spread from person to person as COVID-19 does.
Yeah, absolutely. Well, considering what you just told us, would you say that perhaps a treatment for sepsis might work for COVID-19?
Since COVID-19 is a virus disease, it should not initially be treated with antibiotics, because antibiotics doesn't work against viruses. But on the other hand, COVID-19 is frequently complicated by bacterial infections and clinical sepsis and septic shock. So in these cases, antibiotics will be used in patients with COVID-19 developing sepsis.
Mm-hmm. Well, another potential treatment are steroids, for example. We've seen that in COVID-19. Could these be a potential treatment for sepsis as well?
Yes, and this is an issue of debate. If you're going back some 30, 40 years ago, steroids were administered at a high dose in septic shock. It was the golden standard of treatment because the patients felt much better for 1 or 2 days, and they improved. But after a month, it was shown that mortality increased in patients treated with high-dose steroids in sepsis, septic shock. So nowadays, steroids are used in sepsis in very selected cases only and at a much lower dose. And it's still a matter of debate. Not all ICU, intensive care unit doctors, approve use of steroids, but I think it's a rather frequent approach to use low-dose steroids in certain cases. In COVID-19, I must say that I was a bit surprised myself, but obviously steroids have a very beneficial effect there.
Great. Well, thank you so much for answering our questions. Thank you for your presentation. It was a pleasure to have you on, and we wish you all the best with your continued work.
Thank you. Nice being here.
Next, I'm pleased to welcome Anders Larsson, Professor of Clinical Chemistry at Uppsala University. Welcome, Anders.
Right. Thank you very much, and thank you for this opportunity to talk a bit about sepsis diagnostics. What are we using and what will we expect in the future? I mean, the treatment is important, but the basis for the treatment is a correct diagnosis. So it's really important to have a good laboratory diagnostics for sepsis. If you look at it, every hour counts. A delay of a single hour will increase the mortality. So it's essential that we really have short test around times, which means that as soon as the blood sample is available, we need to be able to run it on instruments that we normally call for random access instruments. That means that you can put the sample in to the instrument at any time, or point of care testing, which also provides very short test turnaround time. The old-fashioned way of having tests that we run once or twice a day, that means 12 to 24 hours delay, and that is definitely not acceptable in a sepsis diagnosis. Something also that is very important is that we have a solid validation of the methods that we use, and we need to have them validated in an intensive care or emergency department setting. Saying that the sepsis patient differs from a healthy individual doesn't really give me that information that I need. I need to be able to say that the sepsis patients differ from, for instance, a patient with a trauma or something else, because a lot of these markers are not highly specific. They can react for other things as well. The basic assays that I'm going to talk about is blood cultures. The next test that we use, that I'm not going to talk that much about, is the temperature. Of course, if you have a high fever, that's a bad sign. I'm going to talk about white blood cells, neutrophils, and neutrophil activation markers. I'm going to talk about CRP and procalcitonin, give you an idea about how we use these markers. Blood cultures, they are very good to have. It gives you a lot of information. We know, for instance, we can do resistance testing, so we know that the antibiotic treatment that we give to the patient is the correct one. The problem is that it takes too long. Normally, you get a test result from a blood culture the next day, and you cannot wait 24 hours to start treatment. You need to start the antibiotic treatment immediately. So the results are mainly used in retrospect, looking at, did I get the right treatment or not? Another problem is that blood cultures are often negative. We have a very good capacity of removing bacteria from the circulation and trapping them in the kidney, in the spleen or liver or somewhere else in the body. If you infuse E. coli bacteria into the circulation intravenously and stop the infusion, after 1 hour, you don't find any bacteria at all. So it's very rapidly cleared. That means that you have a lot of negative results. And that is one reason that in elderly patients, we often take urine cultures as well, because most of the sepsis patients that are elderly start with a urinary infection. So and it's so much easier to identify the bacteria in the urine. And that means that if I do a urine culture, I would get supportive information about the bacteria that the patient most likely have in their circulation. Of course, it may be wrong, but it's still an important part, considering that we lose, approximately 50% of the bacterial blood cultures are negative. And I would assume that here is something that we're going to see a lot more development. For the moment, we have COVID testing by PCR, and that technology will give you test results the same day. And we would assume that we'll see a development of similar technologies for bacterial infections that will speed up the diagnosis. Still, it's not going to be available within an hour, but maybe 6, 8, 10 hours, something like that. So you could get the results before you give the next antibiotic infusion. But still, blood cultures are important, but they have their limitations. And that means that you often work with more unspecific markers. The typical one is white blood cell or neutrophil counts. It's probably most widely used assay for sepsis that we have in the world. And what the limits are really, if you have a high white blood cell count, let's say more than 12,000 per ml, or a low number of neutrophils below 4,000, or immature neutrophils, that's an indication of sepsis. The good part about white blood cell count is that it's rapid. We get a rapid response, and what we see here is, here you mobilize the white blood cells from the bone marrow, so we get it out into the circulation. But these bacteria, these cells are really looking for the focus of the infection. So when it's in the circulation, they feel that there's a bacterial infection, they will adhere to the endothelium and then migrate out of it. And that means that we're just looking at the blood circulation. We're looking here. And if the cells migrate out, we will not see them. And that's the reason why both a high white blood cell count and a low blood cell count is a sign of sepsis. On the right-hand side, you can see what happens with the neutrophils in the circulation. This is just starting the neutrophil count at 100%, and then there's an endotoxin infusion, and you see the number of cells in the circulation drop very rapidly. We're losing 95% of the neutrophils because they are adhering or migrating out of the blood circulation. And then they start coming back, and so they're increasing. They're still there, but when we look at it in normal blood culture, we don't, or a blood sample, we don't see them. So it's a good marker, but it's not optimal, with the limitation that we are looking in the wrong place. We should really look at the site of the infection rather than in the blood. So even if it's widely used, it has clear limitations. Another cause of loss of neutrophils is nets formation, neutrophil extracellular traps, and I'll come back to talking about that later. But as you see, it's not optimal, but it's still something that is important. In most countries where it's used widely, in Scandinavia, we're more focused on the CRP, and we're using neutrophil more to look at very high or very low values, granulocytosis or leukemias and things like that, because we think it's a bit difficult to evaluate the results. If you look at it, I'll come back also talk about neutrophil activation markers, because if you see the neutrophils vanish from the circulation, they're activated, they're adhering to the endothelium. And the problem is then that I cannot get them into the blood circulation as I would like to when I want to measure them. So an alternative would be to use some kind of neutrophil markers that shows that the neutrophils are activated. The advantage with neutrophil activation markers is that I'm not depending on having them in the cells in the circulation. Even if it's stuck on the membranes, I will get the proteins out in circulation. It's so much easier to use. They're early markers because they're stored in the neutrophils. And in my mind, the neutrophils is really our first line of defense. So activation of neutrophils is a good sign in most cases. So here I've just listed a number of markers. You can find these markers. All of them have antibacterial effects. So they will reduce number of bacteria, and the cocktail will give the best effect. The problem with them is that most of them are available in assays that don't give a quick test result. Most of the time it's ELISA plate-based technologies, and the lab will collect them until they fill the plate, and you would get test results in a month or something like that. And for sepsis, that's really way too slow. We need quick results. So we need to convert these into something that is more easily handled, that we can do in all labs. And the ones that probably is the easiest to convert to a routine assay with short test around time is calprotectin, simply because they're the highest concentration in the neutrophils out of these markers that I've listed. And that means that I can get assays that will give you a result in 10 minutes. I think we can develop quick assays for the rest of them as well, but for the moment we don't have them. But I still have great hopes for it. And I'll show you a bit of results with calprotectin later. If you look at calprotectin, this is just adding E. coli to a blood sample. And as you can see here, this is before the E. coli was added to the samples. 1 hour, you can see an increase, and then it just continues increasing. But already after 1 hour, we'll see an increase in the plasma calprotectin levels. So it's a very quick assay because, as I said before, these markers are stored in the neutrophils. As soon as they're activated, they will be released. And the same thing was that I showed you, that they disappeared within 1 hour from the circulation. Here we're looking at the other side, the activation markers, that they release the proteins and they increase. So if I compare that with CRP or procalcitonin, I need a synthesis of this protein, and that means it's going to take 6, 8, 10 hours. So this is a more quick marker. This from a study from Stockholm, where we looked at in the general ICU unit, and we looked at different markers. Here are the same day as the antibiotic treatment was started. You can see that you can focus on the ROC curves. ROC curve stands for receiver operating characteristics. It was developed during the Second World War for the radar operators to distinguish between seagulls and German planes, which you could say it's a bit crude, but it still works. And if you can look here, a high number, ROC number, is shows a good assay. 0.5 is poor, to be honest. White blood cell counts is close to 0.5, which doesn't give the clinician much help. If you have if you have your white blood cells and add procalcitonin, you improve the diagnostics. It's clearly. So in a country where you only have white blood cells, procalcitonin will add something. In Scandinavia, we're very much looking at CRP and use that as a basis for our diagnostics. And as you can see, CRP is outperforming procalcitonin. So in Scandinavia, we're not really that we really don't benefit that much from procalcitonin as an addition. Also, the costs are considerably higher for procalcitonin. You would get about 20 CRP tests for one procalcitonin. But if you go further down, you can see calprotectin has an even higher ROC value. So it's even better than CRP. What you also see, the lower half is the predictive accuracy 1 day before antibiotic prescription. I mean, a sepsis process is a slow process, and when we start the antibiotic treatment, the sepsis condition has been ongoing from very small infection and then accelerating to larger and larger infection. And here you can say that a day before the antibiotic prescription, you can see the same thing. Calprotectin is outperforming the other markers. So it seems that the neutrophil marker is superior to the other ones. And if we had these in the routine, we probably would have been able to start the antibiotic treatment 24 hours earlier, and hopefully, and most likely, will save more lives. But still, we need assays that are rapid. Those results that comes after a month doesn't help us. Here is a similar plot, which is from Östersund, which is in the middle part of Sweden. You can see here is the ROC curve. It's just a different way of presenting it. You would like it to go straight up and then follow the line here. So you have a very, very large surface here, because that indicates a very good predictive value. Here you can see that plasma calprotectin has a rather large area here. It's fairly good. I still would like it to be even better, but it's clearly better than procalcitonin that we have on the right-hand side. If you look at procalcitonin, it's very close to the 45-degree angle. And that means that it doesn't give any information. To be a bit crude, you could say that it's very much like flipping a coin. There's a 50-50 chance that it's positive or negative, regardless if you have an infection or not. And if you compare it, flipping a coin, you'll get the results much quicker, and it's cheaper. You can use your quarter over and over again. So I'm not too impressed with procalcitonin in this study. In the lower part, you can see, well, in some degree, calprotectin and procalcitonin is predicting of the outcome. In this case, looking at the 30-day mortality of the patient. But that's a later step. The really important one is the early one, getting the sepsis diagnosis as quickly as possible. I would like to introduce you to something called NETs, which is a rather new concept. The tradition is that the neutrophils take care of the bacteria or virus very efficiently, and that's the basis for the early protection against microorganisms. What happens is that the neutrophils either phagocytize the bacteria, it just ingests it and degrades it, or it granulates, sends out those enzymes that or proteins that I was talking about earlier, that will bind and inactivate the bacteria. But about 25 years ago, there was a discovery that the neutrophils do something completely different as well. They have something called neutrophil extracellular traps. They more or less empty themselves. They spit out their DNA, their nucleus, sacrificing themselves, forming something like a fishing net here, consists of DNA threads that captures the bacteria or virus and they're caught in this net, and then the enzymes and peptides from the neutrophil will have a much better chance to act on the bacteria and viruses, killing them. So it's a new way of doing it, which is probably more important than we've been aware of. It's been very much shown to be an important part in COVID infections, but it's true also for bacteria. And of course, if the neutrophil empties all it's contained, you don't see it anymore as a neutrophil. Okay, neutrophils are important for the early response infections, for sure. So it's important that they function, and it's also an early marker. The nets is a specific form of neutrophil activation. They trap and kill both gram-negative and gram-positive bacteria, as well as virus and fungi. So it will work on most infections or all infections, especially if you have a normal neutrophil function. At the same time, we know that the neutrophil activation is good in most cases, but it may also cause damage. The nets cause coagulation activation and thrombus formation. What you're trying to do, the nets is trying to do, is capture the bacteria, closing them in, but at the same time you may close the whole vessel, and then you get a thrombus formation, and it activates the coagulation system to make clots, really binding the bacteria in one spot. And if it's too strong, we get coagulation activation and thrombus formation, and may have damage to the body. And that is shown by that nets is associated with acute kidney injury. If I have a too strong an activation or too much neutrophil activation, I will get kidney injuries, unfortunately. And that is a difficult complication to sepsis. We also see that the nets are associated with the severity of lung disease, pneumonia, need for respiratory support. And if we block them with something called PAD4 inhibition or treatment with DNAs, we know that we can reduce AKI and lung injury. So that just shows that it has an important part in the damage as well as the benefit effects. So we need a balance on this. We need good antimicrobial effect, but not too much. And that's really difficult compromise to it. But it also means that we probably will be looking more at neutrophil activation for tissue damage as well as the beneficial effect of the infections. To summarize it, I would say today we'll do white blood cells and neutrophils are key parts. We always will do those tests. Still, the specificity is not that high that we like, and that means that we need to add something more. In Scandinavia, you would see CRP as our first choice. If you go outside Scandinavia, there's not that good availability for CRP, and in most countries, they are using procalcitonin instead. The slides that I showed you before, I think argues for that CRP is superior. It's not only cheaper, but it has a better predictive value in sepsis patients. So I would personally favor CRP. If you don't have CRP, I would go for procalcitonin and potentially IL-6, which is also a very rapid marker. And that is the array that we have today. In the future, I very strongly believe in neutrophil markers, but they need to have a very short test turnaround time. I favor calprotectin because I think it's the easiest one to make and make readily available with short test turnaround times. But I may be wrong, but still some of the neutrophil markers will go a long way, and it will improve the diagnostics, hopefully, and save lives. So this is where I would like to end, saying that today, white blood cells, CRP, procalcitonin, in the future, where we have more validation of the methods, I think neutrophil markers will have an important place. Thank you very much for your listening.
Well, thank you so much, Anders, for this presentation on the challenges of sepsis diagnostics. I'd like to ask you a few questions, if you don't mind. First of all, why is it so difficult to find appropriate biomarkers for sepsis?
There's probably a number of things going on. I think first, most sepsis, if you take it, sepsis is a rather diverse diagnosis. You have a lot of different bacteria, you have a lot of different things going on, you have a lot of side effects, you have a lot of inflammation, which makes it difficult really to distinguish between normal or a tissue damage in general, like a trauma, that also induces CRP and procalcitonin increases from the sepsis. So I think we're going to get more assays for it, but it takes more time, and that's simply because the patients have a great variability in between themselves.
Mm-hmm. Yeah, that makes sense. Well, speaking of time, you discuss a little bit about the time frames for laboratory analysis. Usually, how long does it take to get an answer from the labs?
It depends on how the labs are set up. I would say that our lab normally has a test turnaround time from when the sample arrives to the lab until it has been sent back. The results should not take more than 45 minutes. 45 minutes is a long time for sure in a sepsis patient, but if you then look at it, I think it's essential that the transport is as short as possible. If we have our ward in the same hospital as the tests are performed, we'll get short test turnaround time. If you send it to a different hospital or a specialized lab that is outside your hospital, it's going to take time. The transport time is really essential. And when we talk to other intensive care units, if they have to send it away to a different unit, you have to send it by car or bus or something, and it takes 6 hours. And that is not acceptable, in my opinion. And I think in that case, you should go for point-of-care instruments, because point-of-care instruments usually have an assay time around 5 to 10 minutes. And that means that if you can get the results within, let's say, 1 hour, you should go for point-of-care instrument, because it's so critical with short test turnaround times.
Yeah, I see. Well, that brings me to my last question, actually. So in your opinion, what is the best laboratory analysis, or the most promising, would you say?
I'm a bit partial to the Scandinavian situation. I would say that today we would recommend CRP, but if you go to Central Europe, they would probably say procalcitonin. I think what I'm shown here is that the CRP is better than procalcitonin, but that's the current situation. In the future, I would go for calprotectin as my primary choice, but if the diagnostic companies can develop rapid point-of-care tests for another activation or neutrophil activation marker, I think that would be just as good. But the essential one is neutrophil marker with short turnaround time.
All right. Well, thank you so much for answering these questions and for your very interesting presentation. And yeah, we wish you all the best for your continued research.
Thank you very much.
Our next speaker is Anna-Karin Pennestig, Senior Lecturer in Bioscience at the University of Skövde. Welcome, Anna-Karin.
Thank you. So, my name is Anna-Karin, and I am a Senior Lecturer at the University of Skövde. I was actually born here in Skövde, and when I moved to Gothenburg to study matematiska och naturvetenskapliga programmet at University of Gothenburg and continue with a PhD at the Karolinska Institute, I never thought that I was to return to Skövde, but I did, and I enjoy it. I would like to thank the organizers, Aptahem, for letting me presenting one of my projects within the research area of sepsis, and the possibility to contribute to World Sepsis Day. Since 15 years ago, the Skaraborg Hospital, the clinical lab at the hospital, Unilabs, and the University of Skövde has had a sepsis network to get increased knowledge of sepsis. Here you can see the sepsis team, and the team consists of researchers and teachers, senior lecturers. These are Anna-Karin, Sanja, Diana, and Tove. The team also have a woman that is an adjunct professor at the University of Skövde and responsible for research and development at the Unilabs, Helena. The team also have a senior physician within infections and our sepsis guru, Lars. So currently we're focusing on earlier diagnostics of sepsis, and the network has indeed increased. We have several other international and national partners. I would like to thank all of you for your joint efforts in our projects covering the area of sepsis. And today I would like to give you a background about sepsis from my point of view as a researcher. Then I will talk about one of our projects within future diagnostics of sepsis, that is digital diagnostics and SepsIT. So sepsis. The definition of sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to an infection. The infection can be caused by bacteria, virus, or fungi. In our study, we focus on bacterial infections. Once the infection has started to be systemic, it causes a dysregulated host response, which in the end affects the organ and causes organ dysfunction. And this is life-threatening. Once the infection starts to be systemic, the clinician has only 4 hours to save the patient. And this is due to that the chaotic response in the body causes increased permeability of the blood vessels, which will lower the blood pressure. It also causes impaired oxygen supply to vital organs, such as your heart, the kidney, and the lung function. Your consciousness will also be affected. This can be life-threatening. We also know the following scary but important facts about sepsis. Every 4th second, someone dies in the world due to sepsis. Sepsis develops extremely quickly. The patient can die within 3 to 4 hours. With today's antibiotic resistance problem, we already have a major challenge in rescuing patients who have suffered from sepsis. Research also shows that more people will suffer from sepsis since the known risk groups are growing. And these risk groups includes elderly. This group is growing and we can become older today. While getting older, your immune system becomes weaker. We make more complex operations today. during the operation, there is indeed a risk of infections. Successfully, we can treat and fight cancers today, but these patients are a risk group and can get infections easy since they also undergo an anti-inflammatory treatment. Sepsis is a body's reaction to severe infection. The whole body fights this infection, which causes the lower blood pressure, which is followed by low level of oxygen to different parts of the body. This image shows a classical image found on social media if you Google on sepsis. There's no oxygen supply and the fingers have rotted. If the patient showed this clear picture, the clinician would not have any challenges in diagnosing sepsis. However, the manifestations of sepsis are highly variable. Sepsis have many phases, and it is a challenge to identify the septic patient. Our clinical partners have identified 6 different phases of sepsis, which has been also illustrated by Lars Duvander. So these phases, the first phase is a sudden chill or fever. The second phase is sudden nausea or vomiting. The third phase is sudden change of mental status, such as consciousness or awareness being affected. The fourth phase is sudden muscle weakness. The fifth phase is sudden respiratory distress. The last phase is severe pain. These symptoms, they can be found in patient that has an ongoing heart attack, or if you have maybe been puking for 3 days and caught the stomach flu. And today, we do also have an ongoing pandemic where the virus impact in the body is actually similar to what happens when a sepsis takes place. According to the healthcare system experience, the most seriously ill patients seem to have severe inflammatory reactions and a so-called cytokine storm, which causes an overreaction of your immune response, the dysregulation of your immune system. So yes, we need to improve the diagnosis of sepsis already now. Since these symptoms, the phases of sepsis are very general, it is very difficult to know who has sepsis. So how to diagnose a patient today? As I understand, this is what is happening. The clinician looks into the medical history, measure different vital parameters, and look into the clinical symptoms. The challenge here is that the manifestations of sepsis are highly variable, as I showed on the previous slide. So blood culturing, detection of microorganisms in the blood, is a current gold standard to identify the infectious agent. It takes 20 to 72 hours. Amount of microorganisms in the blood are low. There might be 1 to 10 bacteria per milliliter of blood, if there are any bacteria at all. So this method has a rather low sensitivity and specificity. Time, the clinician has only 4 hours window of treatment. So clinicians contacted us, and we are now studying the future diagnostics of sepsis. We aim to look at how we can provide the clinicians with an earlier and stratified diagnosis of sepsis. And our suggestion and current research area is digital diagnostic, SepsIT. So digital diagnostic, SepsIT, consists of an input, a multiplex biomarker panel. Then data mining will take place and giving rise to an output, a risk score or classification of the patient. I will start to talk about the multiplex biomarker panel. The input multiplex biomarker panel. A biological marker is a measurable indicator of some biological state or condition. Our multiplex panel should be able to tell the clinician that the observed symptoms can be due to a bacterial infection. Already 180 candidate biomarkers for sepsis diagnostics have been published. However, always there is just one biomarker in these publications, being singleplex studies. Today, CRP and PCT are the only two biomarkers used within the clinics. During sepsis, there is chaos in the body. Our sepsis network believes that we should multiplex using 5 to 15 biomarkers. Then which biomarkers? Well, our network conducted the Skaraborg sepsis study during 2011 to 2012. By an ethical approval and informed consent signed by 1,850 patients suspected of having sepsis, we have today a unique biobank and vital parameters from these patients, and we are looking into the following biomarkers. We're looking into proteins and combining them with vital parameters, or microRNA combined with vital parameters. We use different data mining methods in order to develop candidate models. So the data mining methods being used are used in order to develop candidate models based on a combination of a limited number of biomarkers to be able to develop a potential multiplex biomarker panel. The example of the data mining methods we use are artificial neural networks, random forest, bioscore models, decision trunk, discriminant analysis, logistic regression, and classification tree. Currently, we have several potential biomarker panels, but they have not been validated yet. During this journey, we have also understood that we need to develop something more, and that is the output. The clinical decision support system, and this is currently ongoing. So in summary, our idea is the following. The results of the multiplex biomarker panel retrieved from different tests in the clinical lab and vital parameters. These numbers are entered into a digital system. The input is then analyzed and interpreted by a multivariate model, the data mining. And this, in the very end, will provide a risk score, a color code, a clinical decision support of bacterial sepsis as an output to the clinician. So the results are presented to the clinician, who can use it as a support for decision of diagnosing and treatment. This SepsIT is a possible tool for digital diagnostics of sepsis, contributing with an earlier and more stratified diagnostics. We aim to be able to give the clinician the output within 30 minutes to 1 hour. We believe that the SepsIT can have an impact, since earlier diagnostics can give elderly a chance of getting older and enjoy it being healthy. We can contribute to decrease the usage of antibiotics, which will in the end also contribute to sustainable environment. Earlier diagnostics will mean less trauma for your body, and you will have a more sustainable life situation when you come home, and hopefully less severe and no post-sepsis syndrome. And in the end, all this will save a lot of money. In the very end of this session, I also hope that I have been able to give you an increased knowledge of sepsis. Thank you.
Well, thank you so much for that presentation, Anna-Karin. It's very interesting, and your research sounds very promising. I just wanted to ask you a couple of questions, and I wanted to start out with asking how many patients are affected by sepsis in Sweden?
So when it comes to Sweden, we do have some numbers that we also can receive and look into Sepsis Fondens webpage. So in general, what they say and what we say is that more than 40,000 humans are diagnosed each year with sepsis, and 20% of them dies. But it's also a little bit tricky to discuss how many patients that dies from sepsis, due to that there is a special code for patients when you die, and the sepsis code is not always used. It's rather maybe the infection that was so severe so the patient died. So when it comes to numbers within sepsis, it's a little bit tricky and challenging to get the right numbers.
Mm-hmm. Yeah, I seem so. Well, the other question I wanted to ask you is, you've talked a lot about your research, and which multi-marker panel shows the most promising results from the research you've done?
So right now we are focusing on the microRNA combined with vital parameters. And we have right now developed 8 different candidate models. And each of them consists of 6 to 9 microRNAs and vital parameters combined. And what is interesting is that the models can interpret this input data and provide a classification score for the probability of bacterial sepsis as an output. And when we have done cross-validation of the models, we have showed promising diagnostic performance with all of them. So which one is best yet, we don't know. But we have a diagnostic accuracies between 0.77 to 0.94. So in this ongoing project we're doing now, we want to test and validate these 8 models and try to find 3 to 5 that could be the best ones.
Mm-hmm. Well, it sounds very promising, and we wish you all the best with your continued work in this very difficult area. And thank you so much again for joining us today.
Thank you.
Next, I'm pleased to welcome Luiza Jedlina, CSO and co-founder of Aptahem. Luiza will be giving us a short overview of the company as well as their top candidate, Apta1. Welcome, Luiza.
Thank you very much. Welcome everyone, and today we are talking about the Sepsis Day, World Sepsis Day, and this is very important. I would like to talk about our candidate, Apta1, which we think that it's very good candidate to fight sepsis. So I will start with our candidate Apta1. What it is? It's aptamer, and aptamer, it's a fragments of nucleic acids, and from the biology we know that it can be DNA or RNA. The difference is that DNA have double strand and RNA one. What we use for our Apta1 aptamer, it's an RNA aptamer, and beauty of this aptamer is that can create different structures. One can be a secondary structure, or second way it can be created tertiary structure, which gives the aptamer a shape, and the shape can fit to the target protein. But we have to also remember that aptamer can bind not only for the protein, it can also bind to toxins, to whole organisms. So, but in our case, aptamer bind to the protein, which gives alternative to antibodies. So when we talk about antibodies, we have to show the differences between antibodies and aptamers. The first thing and the minor things, it's a composition, and we know that proteins are built from the amino acids, and aptamers, this is the oligonucleotides. Very important part and difference between aptamers and antibodies is a size, and there is a antibodies shown that can be from 6 to 10 times bigger than aptamers, which gives aptamers more possibility to bind to different pockets on antibodies. And the third thing is a production, and very important and very, very good thing with aptamers is that we can synthesize them chemically, which give us very good reproducibility. They are very stable, but antibodies needs much bigger effort because the production needs bioproduction, needs the bacteria or maybe other type of cells. And also through the production there is creation of endotoxins, which they have to be clean after the whole process. So this is the main and the biggest differences between aptamers and antibodies. When we talk about APTA1, and we said that antibodies bind to the target, we talk about also a target for APTA1. And this target is a motif on DBL1 cell surface protein. And now I should explain what it is, this DBL1. DBL1, it's a external receptor on red cells produced by parasite, malaria. And this parasite is hid inside of erythrocytes, which is red blood cells. And this receptors produced by this to bind to microvasculature, which means small vessels, which they will not leave this place and they can survive, they can grow there. And what we used in our aptamer, this DBL1 have a motif called heparin binding motif, and this motif can bind to different receptors even on healthy cell. And we have the red cell, healthy one, with different receptors binding by this motif to DBL1. And when we talk about APTA1, and we know that we have this external, the last motif on the protein, called as DBL1, and we know that APTA1 is binding to heparin binding site on this DBL1, and from evolution we know that this part, this motif, is on many types of different cells in our organism. They can be on the white cells, on the red cells, and also on microvasculature endothelial cells in the veins. So there is the example how it works when this small aptamer can bind to different receptors, different proteins on the surface, different cells, and by binding there they can signal and they can create different effect. And these interactions enables APTA1 to mediate beneficial effects on several pathological processes. When I talk about heparin binding motif, very interesting for us from the beginning was to check if we bind to heparin binding motif, we have anticoagulant properties. And we have it because from the beginning we did a lot of studies on human blood, and we can see that we can prolong the clotting time, called as APTT, or even in the shunt model, we could see that Apta1 administered into the vein can change the weight of the clot. So it was for us very important information that Apta1 have these properties of anticoagulation. But today it's a sepsis day, and we know that in sepsis, coagulation play very, very important role. So why we think that Apta1 would be very good candidate for fight sepsis? We think that Apta1, by binding to the motif called heparin binding site, and this motif can shown on different proteins, shows how complex action and results can give this drug. We have from one side coagulation and from another inflammatory response, and every little dot on this or that side shows that Apta1 can act with them and regulate. This is why we very, very deep believe that Apta1 is very potent candidate for sepsis. When we talk about sepsis, I should show you our first model we tested, and we have really fantastic results. Shows the dramatically improved survival on endotoxic model, and endotoxic model replicate human septic shock. We can see here very high survival in the group of treated animals with Apta1 comparison to untreated. And this model needs endotoxin, or we use the endotoxin LPS from bacteria, which is very toxic, and this is why we could measure this survival in this model. What we seen also, we could see significant reduced D-dimers. And what it is, D-dimers? D-dimers is a very potent marker for checking if the patients will have very good prognostic for the surviving. And at the same time, in the same model, we could see that the treated group have much lower pro-inflammatory cytokines production. But this septic model was not enough for us to understand the mechanism and try to look at the endotoxicity more deep. So we did it also experiment on NHP model, which is much closer to the human, and this is why we think that this is very potent drug for candidate for endotoxemia and even sepsis. So we have 3 groups here, and one control group, the first one, it's a group of animals when they are healthy. There is also animals not treated, but they got this endotoxin, which will be very potent to create some inflammation and coagulation process. And also we have the third group when we treated with Apta1, and we gave this Aptamer twice in different time. After a certain period, we collected the samples and we look at what is really happened in the organism after this endotoxemia. So, I didn't show here, but we also seen that APTT, like we talk about coagulation, was longer. So we could see that Apta1 makes the coagulation work proper comparison to not treated group. But here I would like to show another very interesting discovery when we look at these animals, that we trigger fibrinolysis. And fibrinolysis means declotting. So in this case, we have a TPA, which is a protein and this protein can cleave, can destroy the clot. And also we have the dimers, and the dimers is the product of cutting. So we can see that APTA1 transient, short time working as a profibrinolytic, as a cutting factor, and after certain time it go back to the normal situation when the dimers are not produced, and also even protein is not produced any longer in the group of treated with APTA1 group. When we talk about sepsis, we know and we heard probably about the cytokine storm. And what it is, the cytokines are different compounds, markers in our body regulate the inflammation. And here, in this model, we could see that APTA1 can very strong reduce production of this pro-inflammatory cytokine. And I just showed TNF-alpha, but there is more. There is interleukin-6, interleukin-1 beta, and also it's stimulate production of interleukin-10, which will also regulate production of pro-inflammatory cytokine in the way that it will be much less of them. So it shows very clear that APTA1 can also take care about inflammatory process through the endotoxemia. When we talk about inflammatory process, there is another very important factors, and we call them complement fragments, and we measure 2 of them in the animals treated with this. So we could see clear that APTA1 kept these fragments, complement fragments, on normal level, and not treated animals. The complement fragments start to increase through the time, which is not very good. But at the same time, complements can also promote pathogen elimination. So this is very good situation when APTA1 can keep this on normal level. And the most fascinating thing and interesting data what we've seen through this endotoxemia model, it was the pentraxin-free as a booster of inborn immunity. Why pentraxin-free? It plays a lot of roles and also help with pathogen elimination and tissue repair. So we can see here that APTA1 trigger up to 12 hours very strong production of pentraxin-free comparison to animals without this strong response. So when we can take all of the information what we have about our potent drug candidate, we found this multiple effect, and we could propose our model because we can trigger this motif on heparan sulfate-like molecule. It can act like heparan sulfate-like molecule, but at the same time binding to heparan binding motif. I'm so sorry. And at the same time it triggers releasing of pentraxin-free. So we can see that APTA1 modulates inborn immune response, and there is a lot of mechanisms involved in this. So it modulates clotting system, the clotting system, stops hyperinflammation, promotes tissue repair, and it can recognize and eliminates pathogens. So, take everything together, we are really still thinking that it's very strong data what we have now shows that APTA1 is very potent candidate for fighting sepsis. And I would like to say that we also finalizing information about our mechanism of action, and there will be some very interesting data presented by professor from Örebro, our collaborator, and we still keep a lot of collaborations and collaboration with different partners from Toronto, Örebro, Seattle, Warsaw, and now Poznań. And still we are complied, analyzed our submitting scientific publications, because now we are hard work on this part. And we have also our own place in Lund when we are managing and directing a lot of studies. Thank you for your attention.
Well, thank you so much, Luiza, for the presentation. It's very interesting. It's sepsis, as you say, it's really a tough condition, so there need to be better treatments for sure. So let's talk a little bit about Apta1. I'm curious, you mentioned some of the differences between antibodies and aptamers. What is it about aptamers that attracted you, let's say?
Aptamers are very interesting because they are RNA, and like I mentioned before, they are much smaller than antibodies. They much easier I will maybe show something, so it would be nice to explain when we can see this. I will show this one because you can see that, that this is the protein and there is different pockets, so aptamers can really easily bind and interact with the proteins. And this is, I think, so it was very interesting for me, but also the fact that you can create this by chemical synthesis. You don't need any biological big factory, and you doesn't have any problem with the endotoxins in the production. And also, I think so it's a fantastic tool because aptamers can be they have much stronger affinity to the target because they are smaller, so they can bind very strong. So I think so it's a future, and now we know that a lot of science is interested in this kind of particles like RNA or DNA, and try to work from another side.
Yeah, I think it's very promising for sure. And well, you presented an impressive list of Apta1 effects, and I'm just wondering, why is Apta1 unique against sepsis per se?
And I think so that this is very important question, because Apta1, like I said, can bind to the motif, small motif. We call this heparin binding motif. This motif is on really a lot of different type of cell, but we have to remember that Apta1 bind to very specific motif, one specific motif. And we've seen that this motif, for example, can be on thrombin when we talk about coagulation. And thrombin in sepsis play a very big role, because thrombin can, and it's on this side, the middle of this coagulation process, shows that can play the role with coagulation, but also it's combined with the inflammatory process. So this motif, even on the thrombin, can give a lot of very positive effects on coagulation side and also on inflammation. But we know also that the motif of the heparin binding motif is on different other cells, even in inflammation. So it's extra supporting part that Apta1 can strongly affect these two different processes like inflammation and coagulation.
Okay, very interesting. Well, last question. Well, it sounds in a sense that you have like the perfect candidate, and you've also presented quite a lot of evidence today. What gives you confidence about this evidence that you have?
Especially the biggest evidence, it was our study with this improves of survival. This is very unique that we can see the dose response for Apta1 in the survival mode. So, and the survival was very high. And what we also know, and what gives me very big confidence, is that even if we go from the animals and we are testing humans, we are talking about evolutionary, very old heparin binding motif, which is on every kind of cell. It exists on human cells, on bacteria cells, on mice cells. So whole scope of different organisms are, they have this motif, and this motif play a lot of very, very crucial roles. And it's really binder between inflammation and coagulation. So in front of this data, I am absolutely confident with the knowledge that we can help patients suffer with sepsis.
Mm-hmm. Well, great. Thank you. And it does sound like you have a very promising candidate. And we definitely look forward to following Aptahem in the coming months. And thanks again for joining us today.
Thank you so much. Thank you, everyone.
Now I'm pleased to welcome Professor Mingyao Liu, Professor of Surgery, Medicine and Physiology at the University of Toronto. Welcome, Professor.
Thank you very much. And as we all know, COVID-19 is a pandemic, is a big challenge for all mankind. And it is our intention to try to test if Apta1 could be a potential treatment for COVID-19. So as we all know, the COVID-19 is caused by SARS coronavirus 2. This virus share 80% similarity with the SARS coronavirus, 50% similarity with the MERS coronavirus. The cytokine storm is one of the major mechanisms make the patient into a severe status. So as shown in this slide, the overproduction of cytokines such as the TNF-alpha, IL-1/6, and it's one of the major issue. And also, like many other ARDS, called the acute respiratory distress syndrome patient, the COVID patient also suffer from the acute severe lung injury as well as multi-organ failure. So this slide shows the damage of the lung and other organs. And the injury can be documented by using the CT scan, X-ray film. And also one of the major features for the pandemic COVID-19 is the imbalanced host response. So compared with the regular common respiratory virus-induced lung injury, the antiviral cytokine, such as the interferon gamma family, is significantly less. So therefore, the virus cannot be effectively controlled. On the other hand, many pro-inflammatory cytokines, such as IL-6, IL-1 beta, and IL-8, and many chemokines are significantly higher, which play a major role for the inflammatory cells recruitment to the lung and for the lung tissue damage. So far, many clinical trials have been proposed and approved by FDA and other regulatory mechanisms in Europe, in different countries. People try to find effective treatment for COVID-19. So far, almost no effective or specific treatment has been found. To explore the new treatment for COVID is challenged by the lack of animal models. So the human SARS-CoV-2 do not easily affect most of the animals. So the only opportunity we have is clinical observation. Recently, people try to develop humanized ACE2 mice. So it means we genetically overexpress human ACE2, which is a receptor for the spike protein of the coronavirus on the epithelial cells to mice. So we can infect the mice, then to study the pathological change and to select therapeutic drugs. However, this model is not widely available. Very few places have that opportunity. And also, even you do have that model available, you need to have the level 3 facility. So it means very restricted research experimental conditions in order to avoid infection for the researchers. So in University of Toronto, many years ago, when we studied the SARS, we developed a murine hepatitis virus 1 induced acute lung injury in AJ mice. So what that means is murine hepatitis virus is a type of virus, it's a coronavirus supposed to mainly infect liver. But through extensive research, we found by using the right strain, means the strain number 1, and the right species, the animal strain, like AJ mice, then we can replicate acute lung injury in those mice. So then we can further test potential therapeutics for SARS. After we developed this model, as we all know, SARS stopped suddenly. So the model has been put on shelf, not being used for a decade. Now, with the pandemic of COVID-19, we try to establish this model, then to see if we can use this model to screen potential therapeutics. So in a way, relevant to this meeting is that we try to test the APTA1. So I think APTA1 is very well known to this community, to this meeting. So this is a newly developed nucleotide-based therapeutic drug by Aptahem in Sweden. And in LPS-induced septic model, it has been shown APTA1 can reduce the serum cytokine concentrations, such as IL-1 beta, IL-6, and TNF-alpha, but not influence IL-10 in a dose-dependent manner. And also, APTA1 treatment can reduce the plasma D-dimers concentration, so which is a sign of a change of a coagulation. And APTA1 treatment significantly improved survival of animals after using a high dose of LPS. And also the liver function, kidney function tested through the classical biochemistry shows an improvement in those animals by APTA1. So we consider APTA1 is very good candidate to fight for acute lung injury. So to study this further, we developed two-step approach. The first step is to use the LPS-induced model to re-establish the model in Toronto. So in this way, we will be familiar with the biological effect of APTA1, and also we can confirm that the drug we received, we tested are effective. So if we test on the coronavirus-induced lung injury, if there's no effect, that means the drug is good. The no effect may be true. But if we do not know if the drug works or not, and directly test on the animal coronavirus, if the result is not satisfied, we do not know if this is due to the drug or due to the biology. So that's why the AIM-1 is critical. Let us to familiar with this drug and also familiar to confirm the drug we are testing is effective. Then the second aim will be developing the animal model for the coronavirus-induced injury. So in the first pilot study, LPS model was redeveloped, and animal was given LPS 10 milligram per kilo intraperitoneally. 15 minutes after the admission of LPS, we give animal either normal saline as a control or Aptahem at 100 milligram per kilo as a therapeutic group. So after 60 minutes, the drug or the saline was admitted again. So it's a two doses administration. And then 1 day later, animal sacrificed and sample collected for further analysis. During the 24-hour observation period, and we monitoring animals' behavior to show if any sign of injury that will be recorded. So here we can see in the LPS alone group, the cumulative injury score is 18. The Aptahem treated group, it reduced to 13. Of course, this is very preliminary. We can see there's an incidence for all different kind of a pathological behavior is relatively less in the Aptahem treated animal. The control animal only received the normal saline, no LPS, no drug. So there's no pathological score observed. Then in terms of body weight change, after give animal LPS for 24 hours, there's an increased loss of body weight from approximately 3% to about 8%. And in Aptahem treated group, there's a further increase of body weight loss for the first day. This is only for the first day. We do not do a follow-up study. So this is the body weight change. So then in terms of the blood volume collected, then we notice that for LPS alone group, there's some animals, for example, there's one animal died, then we cannot collect the blood. There's another two animals, the animal is so sick, then the blood collected from the animal is a very, very small amount. By contrast, in the Aptahem treated animals, the blood volume collected is much higher. It's much easier. There's no problem to collect the blood samples. So this is one important observation. So then we take the lung tissue, then using RT-PCR to measuring the gene expression of cytokines. Remember, in the past, the cytokine was measured from blood, from serum. Now this is the cytokine gene expression in the lung tissue. And we found that Aptahem statistically or significantly reduced LPS induced IP10. IP10 stands for interleukin, it's an interferon induced protein 10. And also significantly inhibited IL-6 and also PTX3. PTX3 is an innate immunity marker. It's an acute phase protein produced locally by the injured organ. And it's one of the effective biomarker for ARDS, especially for septic-induced lung injury. So we are very happy to see these results. In addition, we found the Aptahem also have the trend to reduce IL-10, MIP-1 alpha, IL-12 alpha. So those three cytokine level, there's a trend. If we increase the sample size, we might be able to have a statistical significance. So then Aptahem treatment has no obvious effect on IL-1 beta, TNF alpha, MCP1, IL-33. So as we know that IL-1 beta and the TNF alpha are two acute phase cytokine or early response cytokine. So maybe at a 24 hour, it's a little bit too late to see the difference. So if we observe an earlier time point, we may be able to see a difference. So overall, we are happy to say that Aptahem in our own hands effectively reduced acute lung injury and by inhibit the inflammatory response, and also the large blood volume collected from Aptahem treated animal indicate maybe there's some anti-shock or anti-coagulative benefits. So that needed to be further studied, or we can say it be supported by the previous results from the Aptahem older results. So by knowing that, we are currently in the AIM-2. The AIM-2 experimental design is that we first infect the animal with the coronavirus. In this case, it's MHV1. So after different time, then we will give the Aptahem for treatment. So then we will determine if the cytokine storm in the lung shows a significant or not. At this moment, what we have done is we did a time with dose-dependent observation. We tried different dose of the virus to see which dose will induce acute injury. Then we also tried using different timing to admit the Aptahem, then to observe the clinical symptoms. At this moment, this project is still ongoing. We have close collaboration with our collaborators in Sweden and keep them informed of the progress, because the work is not finished yet. So we agreed that we will not present any particular data in this meeting. We'll only report our experimental design and also our progress. So finally, I would like to thank the lab members who are working on the acute lung injury in University of Toronto in my lab. And especially, I would like to thank the people who participated in this project, which is Dr. In-Chun Wang and Chenliang Yang and Junichi Shujihara, and also two PhD students, Olivier and Aaron. And also want to thank Luiza and Mikael from Aptahem for their strong support in the scientific collaboration. And I also thank my administrative assistant, Ivan and Paul, for their administrative support. And finally, thank you for your attention. I would like to answer any questions.
Thanks so much, Professor Liu, for that presentation. It's very interesting to see the connection between sepsis and COVID. And that actually brings me to my first question, which is, what are the similarities and also the differences between a sepsis-induced and a coronavirus-induced acute lung injury?
The sepsis-induced injury usually clinically is induced by bacteria. Then the bacteria release LPS or we call it's endotoxin from the bacterial wall. And LPS has specific receptors called a toll-like receptor. So that's through this kind of a toll-like receptor activate the intracellular signal transduction, then to trigger acute inflammatory response. Coronavirus infection is different in a way. Each one of us may get only a small amount of the virus, but the virus can get into our own cells through the ACE2, the receptor on our cell surface. Then the virus needed to amplify internally inside of our own cells. Then they will really trigger the inflammatory antivirus response. So why is the antibacterial response? Why is the antiviral response? There's a lot of similarity and dissimilarity. The similarity is the all-activated acute inflammatory response for tissue damage. Actually, initially it's for recruiting the inflammatory cells for fighting the infection, but the off-target effect of cytokine can also damage the tissue. The other difference is that the coronavirus, especially the SARS coronavirus 2, not only trigger the antiviral infection, but also compared with the regular virus infection, there's a inhibition on the antiviral effect. So the two effect, the similarity is acute inflammation for tissue damage for cytokine storm. The dissimilarity is the specific biology triggered by bacteria versus virus.
Mm-hmm. Yeah, that's super interesting. And in regard to inflammation itself, what is the role of inflammation in acute lung injury?
So first of all, we needed to understand inflammation is the most important protective effect for our body. Without inflammation, if we get infected, we all die. So inflammation itself is absolutely important for the host defense. It is the so-called excessive inflammation. It's the inflammation out of control that lead to the problem. And so inflammation, so-called excessive inflammation, including you can recruit too many inflammatory cells, then the activation of those inflammatory cells release enzymes, release a particular cytotoxic reagents, then to lead to bacteria or viral killing. So that's what we want. But if it's excessive, then it will off-target the damage of our cells. So if we say police is required for protecting us, but if the police did not control well, then there will be a problem. Maybe there's some civilians who will be shot by the bullets at the casualty. So I think that will be my kind of a example to show the importance of inflammation and the major problem for excessive inflammation.
Yeah, no, that's super interesting. Yeah, we really wish you all the best with the continued research here and also your collaboration with Aptahem. It looks very promising, and we thank you so much for being here, and it was a pleasure to have you on.
Thank you very much for having me here.
Next, I'm pleased to welcome Magnus Grenegård, Professor of Biomedicine with a focus on physiology and pharmacology at Örebro University. Welcome, Magnus.
Thank you very much. I'm really delighted to present research data in a collaborative project between Aptahem and us at Örebro University in Sweden. We are working in a network referred to as Cardiovascular Research Center. And I will present data focusing on disclosing mechanisms underlying the effect of Aptahem on hemostasis. I think it's important to have a quite comprehensive scientific introduction so that you listener can follow the results. If we start with the background, well, Aptahem increases survival rate in sepsis models and causes antithrombotic effect without clear signs of risk of bleeding. If we go to experimental in vitro data, Aptahem modulates a few aspects related to what's called secondary hemostasis. I will come back to that. For example, Aptahem prolongs the APTT test. That's a commonly used test to monitor effects of heparins. So altogether, Aptahem has favorable effects in sepsis and thrombosis models without bleeding risk. The specific aim of this research project, well, it's actually two sub-aims. Firstly, to pinpoint on possible effects of Aptahem on primary hemostasis and shed light on novel pivotal molecular mechanisms that explain some of the observation of Aptahem in vivo. So to the scientific introduction, what is hemostasis? Well, hemostasis is an extremely complicated but normal physiological system in the human body. It's actually, to make it very simple, our defense against blood loss. It can be subdivided into primary hemostasis, and it's illustrated in a simple way below. Primary hemostasis refers to activation of blood cells, specifically blood platelets. And platelets will, during activation, form a cellular plug that reduces bleeding. Secondary hemostasis, on the other hand, is the true coagulation, which comprises a number of plasma proteins, referred to as coagulation factors. The final outcome of activation of the coagulation cascade is the formation of blood clot, built up from a molecular perspective of fibrin polymers. So secondary hemostasis refers to plasma proteins. Primary hemostasis, more rapid, refers to activation of blood platelets. And if we look at this from a pathological angle, hemostasis, both primary and secondary hemostasis, causes either thrombosis or bleeding, or like in sepsis, both thrombosis and bleeding. Inflammation is also a physiological process, but implicated in a number of diseases. Hemostasis and inflammation are indeed tightly integrated physiological systems. I see hemostasis as a direct part of rapid acute inflammation. For example, activation of primary hemostasis, the platelets, causes instant release of a number of so-called cytokines and chemokines that triggers acute inflammatory reactions in the human body. If we considering sepsis in this, well, critical disturbances in hemostasis and inflammation are indeed typical characteristics in sepsis. And if we look a little bit more on hemostasis, sepsis is characterized by thrombocytopenia, also platelet dysfunction, coagulopathy, enhanced fibrinolysis, but also suppressed fibrinolysis activity, and the critical condition DIC. I think, though, that you should be aware of that the results I will present very soon, they are produced from blood samples from healthy volunteers. That's absolutely normal in scientific explorative work. Trying to disclose molecular mechanisms, we have to start with normal blood. I think it's impossible to start with patient samples. So the results are from healthy volunteers. For that reason, I will not talk so much in depth related to sepsis. Finally, I would like to address one coagulation factor because it's central in the research I will present. Coagulation factor 2, F2A, is the same as thrombin, and it is indeed a key player in connecting hemostasis with inflammation. Thrombin exerts a number of physiological effects. I will mention two of the most important, and they are both very relevant for this research presentation. Thrombin is the coagulation factor that binds to and cleaves the plasma protein fibrinogen. And that is the key step in secondary hemostasis for the formation of a blood clot. It's catalyzed by thrombin. Thrombin also binds to cell surface receptors. They are called protease-activated receptors. And this is of main importance for primary hemostasis, activation of platelets. But those cell surface receptors are expressed on a number of cells, not only platelets. They are found on white blood cells, monocytes, neutrophils. They are found on cells in the vessel wall, vascular smooth muscle cell, the vessel wall endothelium. An activation of this class of cell surface receptor causes rapid pro-inflammatory reactions. Bottom left is a simple illustration of the receptor, and these PAR receptors have been implicated in a number of diseases, including sepsis. And finally, to the right, this is molecular details, but still of significant for this presentation. Thrombin binds to PAR receptor and catalyzes proteolytic cleavage of the receptor. So it really acts as a protease. The cleaved receptor undergoes autoactivation. That's the way that thrombin activate pro-inflammatory PAR receptors. We have in this research also used a thrombin mimetic hexapeptide, bottom right, with the amino acid sequence SFLLRN. It's used instead of thrombin, and this hexapeptide binds to the receptor and activates the receptor without proteolytical cleavage of the receptor protein. It's important to remember that. Let's go to the results. First, briefly, the first method. The method to study primary hemostasis functions, platelet aggregation and secretion. It's classical chronolog aggregometry that allows real-time measurement of primary hemostasis responses, platelet aggregation and secretion. And we studied the influence of Aptahem on a number of physiological important stimuli like collagen. Collagen is not a constituent of the blood. It's found inside the vessel. And vessel wall trauma will cause the exposure of collagen to the blood, which will rapidly cause activation of primary hemostasis. We also used thrombin. I talked a lot about thrombin previously. And also an explorative, not a physiological stimuli, fucoidans. But this is of relevance in this research. Fucoidans are heparin-like molecules, carbohydrate polymers with repetitive units with negative charge, which is more or less the same if we look at RNA molecules like aptamers. Finally, we also used this thrombin mimetic receptor agonist, the hexapeptide. Let's go to the results. We start to the left. Here is a summary of the degree of activation. The y-axis indicate the degree of platelet activation and aggregation by using a low concentration of the thrombin mimetic hexapeptide. But firstly, what we can see is that Aptahem doesn't activate primary hemostasis. Furthermore, Aptahem does not enhance or suppress platelet activation induced by a low concentration of a PAR receptor agonist, the hexapeptide. So let's go to high agonist concentrations. And what we can see when using high concentration of the hexapeptide or collagen or the carbohydrate polymer fucoidans is that Aptahem doesn't suppress platelet activation caused by these three activators of primary hemostasis. So primary hemostasis works perfectly fine and is not influenced by Aptahem. But to the right, when using thrombin as the activator of primary hemostasis, we found that Aptahem almost abolish activation. Importantly also is that control RNA is without effect on thrombin-induced activation of primary hemostasis. So the principal conclusion based on these findings, well, in the presence of Aptahem, thrombin loses its ability to activate primary hemostasis. But receptors on platelets that mediates the effect of thrombin are functional. They can be activated by thrombin mimetic hexapeptides. To develop this further, we went to a molecular method, the Fura2 method. That is a method that allows real-time measurements of cytosolic calcium rises in cells. The advantages of the Fura2 method, well, it produces molecular evidence, which is nice, but it's also a highly sensitive method when studying effect of receptor activation. And you can see an original trace to the right. When introducing thrombin, there will be a rapid, pronounced rising calcium in blood platelets. This method is also, although indirect, but it's a sensitive marker for toxic drug actions, for instance, on the biological membrane. And finally, which is also highly relevant, why measuring calcium? Well, rises in calcium is the main molecular mechanism leading to functional responses like platelet secretion and aggregation. Let's see the results. The bar graph shows rises in calcium caused by thrombin. And in the presence of Apta1, the rise is strongly suppressed, whereas control RNA is without effect on calcium rises induced by thrombin. So altogether, the principal conclusion is that Apta1 inhibits functional responses and molecular responses when platelets are activated by thrombin. We have to go back to a scientific background to understand more. To the left, you can see a cartoon of thrombin. Thrombin as an enzyme, of course, comprises an active catalytic site, but also modulatory sites. Exosite 2 and 1 have been recognized for at least 10-15 years. That's modulatory site on an enzyme. And heparins are known to interact with exosite 2. These modulatory exosite comprises clusters of positively charged amino acid. That's the reason why a negative charged molecule that like heparin bind to an exosite. You see a simple cartoon to the right that illustrates how heparin, yellow, interact with thrombin, mainly through binding to exosite 2. And the most studied binding between heparin and human proteins is with antithrombin, AT in red. And heparin binds to antithrombin and binds to thrombin through exosite 2. And this causes a pronounced anticoagulant action. Before we leave this and continue with results presentation, fibrinogen, for example, instead uses exosite 2 when binding to thrombin. Let's for a short while leave primary hemostasis and instead go to secondary hemostasis and experiments we have conducted. Here we see a few results when we have been studying how Apta1 influence on thrombin-induced cleavage of fibrinogen, which is indeed secondary hemostasis. To the right, molecular evidence. Fibrinopeptide A is one of the first peptides released from fibrinogen during the clot process catalyzed by thrombin. And Apta1 does not decrease or increase the concentration of fibrinopeptide A. To the left, it's a really simple but crystal clear method. It's clotting time in seconds of a defined volume of plasma. And thrombin, when introducing thrombin, this volume of plasma clots completely after 45 seconds approximately. In the presence of Apta1, thrombin-induced clotting is unchanged, whereas heparin instead of Apta1 not only delays clotting with that dose of heparin, actually, there is no clotting whatsoever. So what's the principal conclusion based on those findings? Well, apparently secondary hemostasis, the coagulation system, works. So in the presence of APTA1, thrombin's ability to bind to and proteolytically cleave fibrinogen remains intact. So, summary and scientific take-home message. APTA1 is a modulator of the protease thrombin, which is the same as coagulation factor 2A. APTA1 is a modulator of thrombin. APTA1 binds to, interacts with an heparin binding site on thrombin, at least regions of the so-called exosite 2. So it's more or less a competition between a small molecule APTA1 compared to a family of, it's a mixture of large to really large molecules when using heparins, but they share the same principal binding sites on thrombin. The binding of APTA1 to thrombin leads to an incapability of thrombin to activate pro-inflammatory PAR receptors. And for that reason, thrombin can't activate primary hemostasis. But apparently, the receptors, the surface receptors are functional, but they can't undergo activation by thrombin. This effect is actually also seen when using heparin instead of APTA1. I didn't show you those data. But in sharp contrast to heparin, APTA1 doesn't influence at all on the power of thrombin to cleave fibrinogen. And the main reason for that is that fibrinogen-thrombin interaction mainly take place through the modulatory site referred to as exosite 1. Primary hemostasis, the platelets, and secondary hemostasis, the coagulation cascade, are still functional in the presence of APTA1, with one important exception. Thrombin can't activate primary hemostasis. And finally, the incapability of thrombin to activate pro-inflammatory cell surface receptors will cause significant and rapid antithrombotic and anti-inflammatory effects. Okay, thank you very much. I'm done with my presentations and open for questions.
Well, thank you so much for your presentation, Magnus. Very interesting results that you presented today. I'd like to begin by asking how this mechanism that you described contributes to the observed beneficial effect of APTA1 in sepsis.
Well, firstly, scientifically, we should always be cautious when transforming molecular evidence to observation in vivo. But what I can say definitely is that an inability of thrombin to activate cell surface receptors that produces acute inflammation and promotes thrombosis. Such actions are most likely of relevance in a complex and severe disease like sepsis.
Yeah, okay. Thanks for that explanation. I also wanted to ask you, since many drugs do interfere directly and as well as indirectly with thrombin formation and thrombin activity, is the effect of APTA1 different compared to other well-known and clinically used thrombin inhibitors?
Well, it's indeed a relevant question, but the mechanism is certainly different if we compare it with clinically used drugs like warfarin, heparins, direct thrombin inhibitors. Remember that these important pharmacological tools, heparins, warfarins, direct thrombin inhibitors, they produce strong anticoagulant actions. And apparently Aptahem is not an anticoagulant, which is a distinct difference. There is one approved drug in cardiovascular disease to decrease the risk of thrombosis, which is a direct POR1 antagonist. But in comparison, this effect of Aptahem is not on receptor level, it's on thrombin level, the agonist for POR1. So this effect from a molecular perspective is indeed different compared to clinically used indirect and direct thrombin inhibitors. I may mention also, I mean, modulatory sites on enzyme, well, we can stay, we focus on thrombin, of course, but these modulatory sites have been increasingly recognized for some decade as potential important targets in pharmacological research. But I mean, in drug discovery, you can develop hundreds of drugs against the same target, and only one or two of them work clinically. But in summary, if I go back to the question, yes, indeed, the mechanism of action of Aptahem, if we focus on thrombin, is distinctly different compared to clinically used drugs.
Well, to continue focusing on thrombin, could the incapability of thrombin to activate platelets be linked to an increased risk of bleeding?
Well, theoretically, there are always a theoretical risk of bleeding disorders. But remember that when Aptahem has been used in vivo models, there is no signs of bleeding. To make this question quite simple, I mean, there is always a theoretical risk when you interfere with hemostasis with drugs. But from my point of view, I think the risk is probably very small, because primary hemostasis and secondary hemostasis works perfectly fine.
Yeah, I see. Well, the last question refers to Aptahem specifically. Do you think that Aptahem interferes with many heparin binding sites on different target proteins?
I would say yes and no. I'm convinced that there are several interactions between Aptahem and heparin binding sites beyond thrombin. But I think it's important to comprehend that some bindings, if we go to heparin, to a number of proteins, have not been linked to a functional consequence. They are also, of course, dose dependent, but there must be, for sure, other heparin binding sites that Aptahem may interact with and compete with heparins in the binding process. Actually, the data I just presented shows that the most studied heparin binding site on the protein antithrombin, plasma protein antithrombin, apparently, which is so central for an anticoagulant effect, apparently Aptahem doesn't influence on that heparin binding site. So my answer is actually yes, indeed, there must be more, and some may be of significance for beneficial effects observed in sepsis models and thrombosis models, definitely. But I'm convinced that the interaction with thrombin is something that is highly relevant, but it's not the only molecular binding to heparin binding site.
Great. Well, thanks so much for answering those questions, and thank you again for this very nice presentation of yours. And yeah, we wish you all the best with your research going forward.
Yep. Thank you very much. It was a pleasure to have this presentation.
First of all, I would like to share my sincere gratitude and thanks to all our fantastic presenters, and hope that they all brought some more awareness about sepsis, but also insights to how much work and effort that goes behind the quest to deal with sepsis. Please contact Aptahem if you have comments or questions, as well as visit our social media pages. We will do our best to answer as much as we can. Thanks, and see you soon again.